Has a mass.
Yeah, you're gonna find though when you guys get out to clinical rotation, you know so much more than you think you know. You might be at this hospital that you don't plan on being at, and you're like, who cares if I'm a jerk, you know? But then you go to the next one, and they're like, just so you know, that one's a jerk. I had that student before, you know. So the memory is very strong, and the community is small. So you always want to make sure you're putting on that smiley face and happy thoughts and using your brain real good. Right, Mr. Derek?
That's correct. They want to see your thought process. That's one of the things they want to see, like your troubleshooting, your thought process. Are you there to do a procedure? Or are you actually going to be more than just a procedure therapist, right?
Hi, Alicia.
Hi, sorry, I can't hear it. I'm at work. I'm like,
Oh, no worries.
so I'm trying to like set it up to where I can hear, and I'm not like in clinic.
Yeah. And they tend to have not the best Wi-Fi at hospitals either. One of the funny things when I worked at Children's on flights, they had we were the only ones in the hospital that had our own Wi-Fi. Like it was separate from the rest of the hospital. So when the hospitals would go down, we were still downstairs watching movies, like in the office. It was kind of funny. And Derek, I got. It's funny that the lecture that was on there was actually Joe Darmafal's lecture for transport that he would give to us to do when we went out to outreach. And so I've actually done that lecture before, and it's organized really well. So I just sent him a message and asked if he minded if I did that one again. He's like, I still use your lectures all the time. And I'm like, hey, you didn't ask. So, but yeah, so it's a really good, well organized lecture. So I'm looking forward to that one.
Yeah, I think I remember seeing that one at the state conference one time. It was really good too.
Yeah, those are they're fun. You know, it's one of those things where, you know, like it's just interesting because it's not what you do on a regular. Most people don't do on a regular basis, so then it makes it interesting for everybody else. So you always wonder what happens at other places. Like I used to, like for me, like coming to Pima, I was like the teacher's lounge. I want to see what magical thing happens in the teacher's lounge, and it's nothing. It's boring. There's nothing in there. What I always thought of the teacher's lounge to be like, I don't know, like maybe they were playing, like in my mind, they're playing video games or all like I don't know, like whether they're watching TV or something. They're doing something cool, brainstorming. Nothing. It's just a couple people in there, maybe one of them sleeping. So not any even good food or anything.
All right. Is this everyone? Yes, no. All right, so the big thing here, if you haven't done a case study with me, this one is going to be like a Halloween theme one with Jack Nicholson. So this is going to be time for you guys to interact and to speak up, especially when we start looking at labs, blood gases, x-rays, the EKG, all those things. This is meant to sort of combine everything together into one patient scenario, one package. So this combines therapeutics, diagnostics, it combines a bunch of different classes together. So this is where you guys get to collaborate, give your thoughts. Even I have vent settings in there too, just some basic vent settings that we can talk about. So it's not meant that you should know all this information. This is meant to be a learning experience. So take chances, make mistakes, right? This is a fictional situation. So this is your chance to get out there and be like, well, I think it's this and this is why, right? So this is a chance for you to speak up, collaborate, and be interactive with the information here. Any questions before we get started? Oh heavens. I can already tell you guys are ready to interact. You're all muted for some reason.
Oh, here. Do we have to have like a different device? Is this going to be like a Kahoot where we have to click things, or is
No,
it all just us talking right here?
Yeah, I'll lead you through the whole thing. I'll try to get a better format where you can like vote and do poll and things like that. I'll try to do that in the future. So I have a bunch of these that we could start working through. Just depends how everyone responds to it more than anything. So I don't know if that helps or not, but yeah, right now, currently, I'm not expecting you to have that part to it.
No, it's fine. I just wanted to know because, like I said, I'm at work, so I was just gonna have to pick a different area if I needed to do something else.
Okay. Yeah.
I'm happy to be wrong because it won't cause anyone damage.
Just me and Justin. That's all.
I don't care about you guys. So. You're getting paid for this, so let's make it painful.
Eric, are you getting paid?
I get free coffee from the teacher's lounge, so
yeah. You know it's been there since March, right? So.
It's cultured.
Cultured.
It's cultured. Yes. All right, let's get started. You guys ready to go?
Mm-hmm.
Yeah.
Okay. All right. Let me know if this is blurry. Is this blurry for you guys?
No.
No, it's good. Okay, so here's the scene. You're a registered respiratory therapist. You're working at a hospital in Estes Park, Colorado. It's St. Elsewhere here. Dr. Wayne Fiscus is busy and asks you to treat an 80-year-old male in room 8. Looking at the chart, the patient's visiting from Beverly Hills. So the patient isn't originally from Estes, and now they've climbed up to Estes Park. Upon evaluation, you note the patient to be Jack Nicholson. There he is. Oh. He is 177 centimeters tall and weighs 75 kilos. I do put the height in there because that is important later on, especially if you're going to have to do event settings. Does anyone remember the conversion for centimeters to inches? So all of our post-op heart patients that I had in our hospital that would come out of our ER, go through our OR and then come to ICU after their cardiac surgeries, they would put their height in centimeters. So this is something I had to do all the time. So this isn't me just, having fun with you. This is, you might have to actually do this conversion factor in the hospital. So remember?
Multiply by 2.54? No? Okay.
You're close.
You divide.
Divide, yeah.
Right?
177 times 2.54 would be a lot. So divide by 2.54 here. So 177 over 2.54.
The internet is telling me it's 0.4 inches per centimeter.
Or you can do ratio and proportion. That's an option. So if you divide by 2.54, how tall is Mr. Nicholson?
About 5'9".
5'9", okay. So that's 69 inches when we get to mechanical ventilation. All right, on evaluation, you see him in Fowler's position. Do you guys remember what that is?
Mhm.
Fowler's, isn't that when they're like hunched over on all fours? Or not, well, not fours, but are they hunched over?
He is not hunched over.
Oh, okay, then I don't remember.
Is that seated?
Sit it up.
Yeah.
Yep, he's sitting up. He's on 15 liters a minute on a non-rebreathing mask. The bag is good and inflated throughout the whole respiratory cycle, which is appropriate. They obtain notes from his hotel room. So the notes from his hotel room states the following. He was visiting the Stanley Hotel for a paranormal convention. Sounds appropriate. He was walking up the stairs to room 237 when he started feeling funny, felt like he couldn't breathe. He was very dizzy. So those were his symptoms that he had walking up the stairs. Feeling funny, felt like he couldn't breathe, and dizzy. He stated in his notes, "I don't know how I made it to my room, but I woke to find the middle of the night feeling like I was being choked." So he felt like he was being choked in the middle of the night. He was sweating. His heart was racing. He felt nauseous. He had trouble breathing. He was confused, and he's like, "I feel like I'm not myself," feeling like his energy was being drained. And he had blood around his lips and on his pillowcase and the taste of blood in his mouth.
Mm-mm.
Let me know if you need me to pause here for a little bit. Is anyone ready to set this up as a ghost thing?
You.
You ready to move on?
Mhm.
Oh, 1 second.
Okay.
I'm good.
Okay. He remembers seeing visions. So these are all things he's written down. He remembers seeing a vision of a clown, a mental health patient, a military person, a cowboy, a bartender, and some children. So he's seeing weird things. Yes. So definitely he has an altered mental thing going on. Something's going on there. He awakens again, scared, and he's feeling pressure on his chest. Pressure on his chest. So those are all things that they were able to obtain from his notes in his room. Now it's your turn to evaluate him, to use your bedside assessment. They found him on the floor in his room. He was making odd statements, and then they called 911. He has a past medical history, so this is his past medical history of smoking. So he has a smoking history, drinking, memory loss, various STDs, recreational drug use, hypertension, which he's not compliant with his hypertension medicine. So that's his past medical history. Do you guys need to go back, or you good?
Yeah.
Okay. Current vital signs. Do you want to know his current vital signs?
Yes.
Yes.
Yes, please. Heart rate's 125. His respiratory rate is 32. His blood pressure on his right upper extremity is 95/86. 95/86. His temperature is 36.5 centigrade. And his pulse ox is 84% on a non-rebreather, but it has very poor heart rate correlation. So the reading is a little unreliable. So non-rebreather mask, what can you guys tell me about a non-rebreather mask?
It's low flow.
They're- Yeah,
It's
they're
not low
getting
flow.
FiO2.
No?
High flow. No,
High
it's all
flow, high
High flow.
FiO2, and he's only
O2.
setting 84% on that.
He might be breathing in his own CO2 from the bag. Turn
Well,
up
the bag was completely inflated through the whole respiratory cycle. I like your thinking, but the bag was completely inflated through the whole respiratory cycle. In other words, it was more flow than what he was requiring. So it was definitely appropriate. Do you want to listen to his lungs?
Yes.
Yeah.
Yes, please. Poor air movement, intermittent crackles throughout the whole respiratory cycle. So normal or abnormal?
Abnormal.
Abnormal.
Abnormal. Respiratory pattern. Do you want to look at his pattern of breathing?
Yes.
Yes.
Rapid and shallow. He is using accessory muscles significantly. So he's working hard to breathe there. Do you want to listen to his heart sounds? It's free.
Yes.
No.
Soft heart sounds. Very, very soft heart sounds.
So it's soft heart sounds with a heart rate of 125.
Correct. And a blood pressure of 95/86.
Okay.
On evaluation, do you want to do some diagnostic chest percussion?
Why not?
It might tell you more about his lungs. If it's a dull sound or a resonant sound. Do you want to do diagnostic percussion? Yes or no?
Yes.
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 It is dull bilaterally. So hopefully you remember what that means. What does this mean? H-E-E-N-T.
Sorry, I don't have idea.
No? This is part of patient assessment. What is it? If you see this in the chart, what were they checking?
It's head, eyes, ears, nose, and throat.
Correct. So
Good.
on evaluation for HEENT, there was no lacerations or bruising noted on his head. His head was normal cephalic, so it didn't feel bulgy or anything like that, like a trauma, like he fell down or hit his head or something. So that wasn't noticed. What's PERLA?
Pupils round, forgetting. Normal.
Pupils equal round. Yeah.
And accommodation.
You're close.
Is it pupil qualities, or let's see.
Is
Pupils
it
equal
light?
round, reactive to light accommodation?
Pupils equal, round, reactive to light and accommodation.
Okay.
Yes, so he has PERLA, so that's a good sign. His tympanic membrane's intact. Remember, he was feeling dizzy, so is that important information to know?
Yes.
Absolutely. His nose is intact, thank goodness. He has moist mucous membranes. No tracheal deviation or JVD. What's JVD?
Jugular vein distension.
Okay. Interesting. Which is usually a sign of what?
Heart failure.
Right-sided heart failure or cor pulmonale. No crepitus noted. What's crepitus?
Is it the thing in your eyes, like the little discharge from your eyes?
No, not necessarily, no. This is a palpation.
It's
Fractures.
from your bone, like
Not for bones.
crepitus is a common sign.
Is it a sound?
Oh, it's caused by fluid-filled air sacs that are opened when you
And bubbling.
So it's little like, they always described it in schools like Rice Krispie treats. You press on their upper, lower neck, upper chest area around the clavicles in that area. You'll feel these like air bubbles like popping. That's usually a sign of what? If you feel crepitus, also known as subcutaneous emphysema, what's that a sign of? Might see it in emphysema.
COPD.
Something that can happen with COPD.
Fluid buildup?
Not fluid. They're air pockets.
Mucus,
They're
No.
atelectasis.
air pockets underneath the skin. Should air be underneath the skin?
Oh, no. Okay. I remember talking about this. I forget what it's called, though.
So subcutaneous emphysema or crepitus is what you're palpating, and it's a sign of a pneumothorax.
Yeah.
Right, so like a bleb could have popped, things like that. And then we'll talk about that in disease class a little bit too. What is a PMI?
PMI Medical Institute.
Yeah.
Point of maximal intensity.
Point of maximal intensity, which tells you what? Why is it important to you?
It's to let you know, like, the patient's, like, breathing, like, if they are able to breathe in fully.
This is a cardiac auscultation.
Oh.
So this is where the heart is the loudest, right? What would that change? Why would that change? Where is it supposed to be normally?
At
Apex.
On your chest topography, where is supposed to be the PMI?
Is it around the 5th intercostal space?
Mid?
Clavicle?
Mid-clavicular, very good. So if it's shifted, let's say I hear the PMI more towards midline, more towards the sternum, that could be a sign I have a massive pleural effusion or pneumothorax that's pushing the heart over, right? Or it could mean the opposite. If it's over to the left more, if it's more axillary, then that's a sign I could have a massive pneumothorax on my right side that's pushing it, away. So it's sort of something to look at is that PMI. Is the PMI where it's supposed to be? If it's not, that might actually help you clue into what's going on in the thoracic cage. So his PMI is in normal position. I know I went through all that just to give you a normal answer. All right. Do you want to see if he's alert and oriented currently?
Yes.
Yes, please. He is aware of person. His knowledge of place. He says, I'm at a Lakers game party. So is he currently doing well in the knowledge of place? No, he's an ER roommate, right? Knowledge of time and date. He says today is May 23rd, 1980. No. So his mental status is a little off. Knowledge of event. I don't know what happened. I may have eaten something funny, is what he stated. Why are you here? I don't know. I think I ate something funny, is what he responds. Do you want to check his Glasgow Coma scale? So this is another neurological or physiological response, right? All right, so I'll ask you to score this for me. So if you have a resource that has the scoring system for the GCS, I'll give you a chance to practice scoring this. So GCS. His I response is to verbal and.
3.
You tell me. We got to go through them. All right, so you got to add them up at the end. His verbal response is inappropriate words. His motor response localizes to pain. Localizes to pain. So what score would you give his GCS?
13.
11.
11.
Good job. Good job. What's the highest score you can get?
15.
All right. So skin evaluation. Do you want to check his skin? It's free. It's not going to cost him anything.
Yes.
It's pallor and cool. Pallor is a fancy way of saying?
Pale.
Pale, yeah. Yeah, just pale and cool. Cyanosis would be the blue there. So that would be an example, pallor and cool. thought it would be fun to use pictures with it. All right. His pulse strength. Do you want to check how strong his pulse is?
Mm-hmm.
Yes.
His pulse is weak. Very, very weak pulse. Remember, his blood pressure was under 100. He had a rapid heart rate and a lower blood pressure there for sure. Do you want to check his cap refill?
Yes.
Yes.
What does cap refill tell you about?
The flow, so like your cap, like if you palpate the skin, it lets you know how much blood flow is actually getting like back into the capillaries.
So it's that perfusion aspect. So it's a way to look at cardiovascular stability or instability if you're looking at it. His cap refill is 6 seconds. Tell me if that's normal or not. You tell me.
That's bad.
Abnormal. It should be like 2 seconds, right? 2 or 3.
3 to 5.
So it's 6 seconds. So if you normal is 3 to 5, then this would be a long or delayed cap refill. Urine output. Do you want to know his function of his kidneys?
Yes.
He says he cannot recall the last time he used the can. Those are his words. Babinski Reflex. This is a neurological assessment tool. It's usually muscular skeletal response when they're looking at this. Do you think he has, it's appropriate to run a Babinski reflex here?
No.
I got a no. Agree, disagree?
If you go ahead.
I thought they
I-
only did it in kids.
No.
No? Sorry.
No, you're right. Well, no. That's where you should have the reflex.
So Babinski.
What is that for?
It's like when you do the thing on the foot, right? Like you just stroke it to see if like the toes move. Oh, I'm sorry.
No, you're doing very well.
The Babinski reflex, you were right, Sarah, is on the toe. It's like a stimulus, so they want to see if is it like a pain stimulus? But I don't think it's appropriate for his situation.
Let's see.
I feel like it can't hurt to do it though, because it like doesn't cost anything.
And I mean, if he doesn't have any feeling in his extremities, that would give us information about whether or not he has decent blood flow over there.
Do you have evidence that already suggests his blood flow is poor to his extremities?
Yeah, the capillary refill.
His capillary refill.
So yes or
it
no?
could explain tissue damage in the extremities if he has hypothermia. I'm going with yes.
Yes.
Physician disagrees.
Say no.
Deep tendon reflex. Deep tendon reflex, yes or no?
Said no to that. No.
Dwayne says no.
I don't think they would need one.
I don't think so either.
Physician disagrees. Good job. Extremity evaluation. In other words, you look at his hands, his legs, his arms.
Yes.
He has peripheral edema bilaterally on his lower extremities. He has some edema on his legs. You guys having fun so far?
Mm-hmm.
Yeah.
Stressed out.
It's okay. It's okay. All right, Dr.
It's
Wayne
so
asked you
nice.
for tests to run. What about a lumbar puncture? Is it possible that he needs something where we need to evaluate his cerebral spinal fluid? Things like meningitis, Guillain-Barré. So they do this for different types of things out there. Is it possible that we need to evaluate his cerebral spinal fluid?
Possibly because he's having hallucinations.
So I hear a possible.
I'm gonna say no to that
I
one.
hear another
I'm gonna
no.
say no because I feel like that could be a procedure that may not have been necessary and it could end up costing the patient.
I mean, in place of that, couldn't you just run a blood test?
A CBC.
To see if if anything's elevated first.
So I'm hearing no, but a possible with
No.
Mr. Marks there.
I think there's other things that, like Sarah's saying, you could do first before you go directly to that.
So as far as a lumbar puncture at this time, the physician does not want that at this time. A VQ scan. What's a VQ scan?
Ventilation, perfusion.
Ventilation perfusion. What does it look for? What are we evaluating with a VQ scan? What condition traditionally?
Is this for pulmonary embolism?
Yep, so it's one of the classic things to look for here is a pulmonary embolism. Do you think that's appropriate currently, or is this something that you would recommend to Dr. Wayne to run on this patient?
It
He
might
did
be
fly
appropriate.
from LA to at altitude.
I would say yes, because we already discovered that his capillary refill isn't the best. And like the VQ can also just be used for blood perfusion scan or like the blood flow. So VQ could be helpful
And he also had
to see if there's something.
oh sorry. He had the pulmonary the edema in his extremities, peripheral edema.
Mhm.
Isn't that like a sign of like a blood clot or sometimes?
It can be a sign like a DVT, things like
It
that.
can be. Yeah, the DVT.
And I feel like combined with his low blood pressure.
Low blood pressure. He did have low blood pressure as well.
He also was on a flight where you can get DVTs, so a blood clot could be possible, which would inhibit the perfusion.
And it would cause his saturation to be low on high FiO2s. It's a dead
Yeah.
space process. Do you want to do a VQ scan?
Yes.
Yeah.
Yes.
Anyone opposed? No. Physician disagrees at this time. What about an arterial blood gas? It's the gold standard for oxygenation and ventilation.
Yes.
Yes.
All right, interpret it for me. 7.34, CO2 of 55, PaO2 of 57. He's on 100% oxygen. Bicarb of 19, a base deficit of -7, and a saturation of 93% on blood gas.
A mixed respiratory acidosis with
Well, if it's mixed, it's not a
moderate.
respiratory. It's respiratory and
Yeah,
metabolic.
mixed acidosis,
Mixed
moderate
acidosis.
Hypoxia,
With uncorrected.
uncorrected, moderate.
Well, mild, moderate, severe is only if they're on room air.
Okay.
So this would be a mixed acidosis with uncorrected hypoxemia.
Hypoxemia.
Bringing blood gases into it. Love it. So just looking at the blood gas, does he have trouble ventilating, oxygenating, both? What are his issues with this blood gas? I need sound effects here.
Is that like
Dun dun dun.
There you go.
Definitely trouble ventilating because he has a high CO2, but his SaO2 is 93, so it seems like he has a decent amount of oxygen.
Remember, you can have good saturation and a low PO2. That would be a left shift of the curve. With the left shift of the curve, do you still have adequate delivery of oxygen to your tissue?
no?
No. So, something to pay attention there. What do you know? The oxyhemoglobin dissociation curve rears its head again. Love it. X-ray. Do you want to look at an X-ray? Chest X-ray.
Yes.
Yes.
All right, they went ahead and ordered it. What about an EKG, a 12-lead EKG? He was having issues with pain on it, like pressure on his chest. His blood pressure is off. He's running a fast heart rate. His capillary perfusion's poor. He's not urinating, so his electrolytes, like that could be off. Is a 12-lead appropriate?
Yes.
Yeah.
They ordered it. Guess what you guys are going to have to look at in a little bit here. BNP. BNP.
Got the brain natriuretic peptide.
What does it tell you about the function of what does it tell us about? What information does it give us about our patient?
Heart impairment?
Yeah, heart function. So if this level is super high, does that mean a heart's doing good or a heart's not doing so good?
Not doing good.
It's not doing good.
So is that
he could be in
something?
heart failure.
Is this something that you guys would want to look at on him?
Yeah.
Yes.
All right. It is 450.
It's supposed to be lower than 100.
You tell me.
I don't remember, and I don't know where those notes are right now.
Okay, hold on. So the normal, yeah, is right, 100 picogram. Oh, 100 pg per ml. Oh wait, yeah. So more than 100 could indicate heart failure.
Valuable information, yes or no? CBC. So it looks at white blood cells, H&H. All right, you tell me if there's anything off. Red blood cells, 5.6 million. His hemoglobin's 15, his crit's 48%. His white blood cells are at 8,000, and his platelets are at 300,000.
His hematocrit could be a little low. Or is it 40 to 50?
So you think he could be anemic?
No.
Okay.
No.
It looks like all his values are normal.
Yeah, his hemoglobin is normal.
Yeah, it looks like.
Good. Platelet count's good. White blood cells good.
Do you guys remember?
It looks like everything is good.
Yep, everything looks good. Do you guys remember in pulmonary MP when I talked about HAC, histotoxic, anemic, circulatory, and hypoxic hypoxemia? Way back in the day in first semester. So if someone has trouble oxygenating and they're ventilating fine, one of the things that we could look for is HAC, histotoxic, anemic, circulatory, and hypoxic hypoxia. So that's one of the things that we might want to sort of pay attention to here as well. LFT, what's an LFT?
Liver function.
So is that something that we would want to look for here? And if so, what information would it give us? Like, why would it be important to us to look at his liver function?
So would that be part of the reason he's in acidosis?
So you're saying if it's high or low? So LFT looks at liver enzymes. So if the liver enzymes are high or low, would it mean that his liver is functioning bad?
I think low.
So if he has low liver enzymes, his liver is not functioning well.
Well, because if it's high, his liver could be like injured or like damaged.
So
Right?
high LFTs are something to be concerned about. That's a sign that that
Concerned
organ
about
is
'cause it's
sick or
not working.
damaged. Yeah.
Okay.
So is that something that we'd want to be aware of here? Is that something we could look at here? Or we should look at here?
Yeah.
Yeah, he said he was a drinker. He drinks.
So LFT levels, yes or no?
Yes.
Yes.
All
Yeah.
right, you interpret it for me.
No.
Dwayne, I'm at work. If you have the book, I need you to help me out.
I'll give you a heads up.
ALT,
My AST was 1200 when I got it checked after a race.
so the reference range for ALT is 7 to 56, so that looks high.
Yeah.
And then AST
And
is
AST
0
is
to
40.
35, so
Oh,
they're
okay.
both pretty high.
So his liver, not doing
Is
so well.
not functioning well.
So his BNP is high, his liver's not doing so well. All right, do you want to check his serum electrolyte levels?
For sure.
Yeah.
He did have a mixed acidosis, for those of you that are just remembering the anion gap stuff in the back of your head. Electrolyte
Yes,
levels?
he's doing it.
All right,
Yes.
there they are. Sodium's 85, potassium's 2, chloride is 100, and bicarb, serum bicarb is 19.
Okay, so sodium is low.
He's hyponatremic,
Potassium is low.
Is low.
hypokalemic.
His bicarb is
And his chloride is normal.
Chloride's normal, and that's a serum bicarb, not a blood gas bicarb.
And that's
that one is a little low. It's on the lower side.
So what information have you gained from this? He's
Yeah.
hyponatremic, hypokalemic, and his bicarb is also a little bit low. Well, why would his bicarb be low? What was his renal function?
It was high.
His renal function was good, or his renal function was bad? When's the last time you went to the bad, right? So that sort of makes sense that the bicarb would also be low as well. Troponin. This is something we look at for people that have chest pain. Myocardial injury is something that we can see with elevated troponin levels.
Yeah, let's do it.
0.8.
So that's twice the normal value.
Yeah.
Now, keep in mind, can troponin be elevated for other things that are not a heart attack?
Yeah.
So, something to think about there. BUN and creatinine, they both evaluate renal function. Do you want to look at those?
Yes.
Yes, they are indicated. His BUN's 40, his creatinine is 2.
So his BUN is high.
Mm-hmm.
His
creatinine is high.
Is high.
So renal function? Not doing so good.
Bad.
Do you want to look at an echocardiography? Looks at the heart function, live 3D. Is it indicated in this case?
Well, if we're getting, I guess I don't know enough about like the 12 lead EKGs, but like, don't they give like What's the advantage over this one, over the other one?
The echo is a live 3D picture of it, so you can see the actual function or motility of the heart. You can also estimate cardiac pressures like pulmonary artery pressure, ventricular pressure, things like that as well. You can see if there's a hypokinesis or low movement of the ventricles, things like that. So it can give you a much better picture besides just the electrical activity.
I'd say yes.
I'd like to do it. I mean, we generally know, but it'd be cool to see.
For fun.
All right, so this is his
I mean,
X-ray.
he's
It's a
got
poor-looking
money. He can
X-ray.
pay for this.
Whoa. We don't know that.
Let's not get into that here. Okay, so let's look at the X-ray. What do you guys notice, those of you that have looked at some of these already? Does this look like a
I don't think we've
normal?
done X-ray yet, but it's not normal. He definitely on his left side.
What's on the
I
left
think
side
his
that
heart
you're?
is enlarged. I think his heart is like got a space, like too much space.
There's a lot going on in the center.
Well, that
There's a
would
lot of
be,
parahilar infiltrates going on, is what I'm hearing.
would that cause the dull chest sounds?
Remember, dull is dense or thick tissue, so it could be inflammation, it could be fluid, it could be it could be a pleural effusion with dull chest percussion. So dull means
Okay.
something in there is like deadening the sound. So like it
Okay.
could be inflammation, could be fluid, could be a number of different things. So he has a large.
So I mean, without taking X-ray, he has something that's obviously restricting that area and making, like, you know, the hard to breathe or the pressure on his chest or that feeling of chest pressure.
Yeah. And
I
then
just don't know if it's air or fluid. I don't know.
well, he also had, when in the beginning it said like he had blood on his pillow and like in his mouth, so it might be like pulmonary edema.
Like a hemo.
Mm-hmm.
Yeah.
And he doesn't have good lung expansion either.
Or perfusion, so.
Blood pressure is low, yeah.
Yeah, so something's like compressing the heart so much that it doesn't have good ventilation.
Like a tamponade or?
That's right too.
I don't know, Derek.
This is a learning
I'm
experience.
trying to look at it. I haven't done X-ray, so I'm trying.
That's okay.
I know.
I have a lecture on it that's already in your resources. So that's
Okay,
something for you to
I'll
look
pick
at
it up.
later. All right, you guys are ready to move on from
Am
the
I right in saying it's restrictive though? That something restrictive is happening for sure?
He does have low lung volumes. He does have a large cardiac silhouette, and he does have a lot of parahilar infiltrates, a lot of fluid that sort of sort of haziness around his like sternum area there. So those are all not normal.
Okay.
And then also you see here, do you guys see my mouse?
Mm-hmm.
So that right lung, you see how flat that is? That is a flat diaphragm. So that can indicate pleural effusion or hyper expansion. In this case, it is not hyper expansion because he only has about 9 ribs expansion there. So there's something also going on in his pleural space too. But I'm giving away a lot here by saying that.
Please give more.
Are you ready for the 12 lead?
No, you're not.
Yeah.
All right, interpret this 12 lead for me. So down at the bottom here where the mouse is, this is lead 2. But also notice on his leads, there's a big amplification of his electrical impulse in leads 4, 3, especially. Ventricular lead 3 and 4. See how high that amplitude is?
Mm-hmm.
Also notice the T-wave. So down here on lead 2, notice the way the ST segment. That's an interesting ST segment there.
Mm-hmm.
And also, remember his electrolytes. Hypokalemic, hyponatremic. Do those have anything to factor into this?
Yes.
Yeah.
So what are you seeing that's different? Is this a normal 12-lead finding, or is this an abnormal 12-lead finding?
Abnormal.
Abnormal.
So what are you seeing that makes it abnormal?
Well,
It's a narrow QRS.
That's
Yeah.
good.
Very
That's good.
narrow QRS.
ST segments are weird. Or I'm sorry, the T. Wait, yeah.
The ST segment. Yeah, you're right, Sarah. He has like a lot of depressions at his isoelectric line.
No P wave. Is there a P? There's no P wave on there.
So on lead 2 down here, you see P
I
wave.
see a little one.
Yeah, a little.
P wave.
Yeah.
Notice that
P-wave.
it's spiked too. It's not contoured.
Yeah.
So the
Pregnant.
electrical imbalance is causing
Weird.
That's this.
Yeah, I don't know what to make of the T wave being so weird. I guess ventricular repolarization, something weird is happening there.
So can repolarization be affected by your electrolyte balance, especially if you're low in potassium?
Yes.
Yeah.
Does that make sense why you're seeing that here?
Yeah.
What about the really, really high amplitude on leads 4 and leads 3? Ventricular leads 4 and 3.
What was his oh shoot. His sodium level or whatever?
So what side of the heart does lead 4 and lead 3 look at again? Are those looking at it from the right side?
Well, the 1, 3, and what other one is like a bipolar lead? So they look at
the side.
I'm not gonna say this. Never mind. I don't know what I'm talking about.
Most of us don't, but that's the point. So, yeah.
Jason, what was it again about the leads?
So I'm wondering, so when you're on a 12 lead, they're all kind of giving a different view of the heart. So if we're seeing it on lead 1 and lead 3, I'm wondering kind of what view we're seeing.
That's the triangle that's like the triangle people talk about. So you're getting it from 2 different angles, right?
Yes.
So I think you're seeing that from, is that you're seeing it from the right and left side? I think Jason's trying to figure out if it's top or bottom.
Hold on, maybe if I show you a picture, hold on. I don't know if this will work, but like, these are like leads 1, 2, and 3. So these are the ones that are looking directly at the heart at like a view like this. But
Notice what side of where's lead 3 on that picture that you just showed? What side of the heart is that looking at? The left side or the right side? The left ventricle, right ventricle?
The left ventricle. Well, no, I'm sorry. Wait.
I think it's the right.
Sorry.
Because of the bipolar lead, it goes from, it's on the right. So is it the right side of the heart?
It would be the right side. Sorry.
You have the triangle. I think it's the right side. So it's the right side, but I don't know if it's like the top or the bottom or if it's just that entire side.
Lead 3 is the left, right?
Yeah.
3 is left, 4 is left, 5 is left, and 6 would be also left.
Only 1 and 2 are right.
Traditionally, lead 3 would be more of your intraventricular space if you're thinking of a 3D heart model. So the septum, that intraventricular septum space. So when we hit lead 2, 3, and 4, there's a little bit of amplification in lead 5 too. You see the amplification there. But it's significant that the electrical activity is so strong in there. So I'll leave it there. But notice that it came into play that his electrolytes did cause ST changes, right? Delayed conduction, delayed repolarization. Yes, and then the amplified QRS complex is also going to play a factor into what's going on with it. All right, so let's move on. Recommendations. Would you recommend giving this guy, he has low blood pressure, a liter of normal saline because of his hypotension? In other words, this would help improve his perfusion to his kidneys. It'd help improve his perfusion to his liver. It would help his blood pressure come back up to a normal level, because that might be why he has an altered mental status as well, right? Low blood pressure to his head. So would you guys want to recommend a liter of saline to help resolve his hypotension?
Yes.
Dwayne says yes. Give him a liter.
People, come on.
I say yes, because if he was also like pale, any of that color, so, and we already know it's an electrolyte imbalance, so fluids will help, like you said, correct all of that to get the flow going correctly from like the kidneys.
Anybody have opposing thoughts?
I don't know if we're wrong.
No one opposes?
You're making me want to oppose, Derek.
I'm here to make you think, not oppose.
No, I'm for it.
I'm just trying to think if there's something else in his vitals that would suggest not to, but.
Vitals or labs?
I still say yes.
So give him fluids?
Yes.
Physician disagrees. We'll
Because he
talk
hasn't
about
urinated?
this.
Is it because
talk-
he's already having edema?
I don't
Well,
think
if
it
he had-
necessarily has to do with the edema aspect of what's going on.
Would it be the poor renal function if we give him more fluid?
Sounds like he's in renal failure.
The more fluid he has, the more pressure it might put on his vessels?
So it would actually help his renal perfusion, in theory. But with what's going on, Wayne's got something in the back of his brain. He knows what's going on with this guy. So that's why he's disagreeing with fluids, and we'll talk about this, okay? Diuretics, that pulls fluid off of his system. It actually decreases blood pressure as well when you pull vascular fluid off of someone. He does have edema. Diuretics is a treatment for heart failure.
Maybe just not now. I feel like if we put him on diuretics with his blood pressure already low, that might be a problem.
I like the way you're thinking there. So
Yeah, I would say no, because he's already hypotensive.
Yeah, not in this case,
And his
right?
labs are already.
Yeah, and it can throw off his electrolytes too, right? That can you not only pee
Yeah,
off sodium,
labs
right? So that would causes even more hyponatremia. Hemodialysis, this is an artificial kidney type thing where you take blood out, filter it, stuff. Hemodialysis. It's for renal failure.
Yeah, he's in, but he's not in renal. Well, okay, I'm sorry. I didn't write down the part about the ABGs. My bad. That's on me. You said he was mixed, right?
It's a mixed acidosis.
Mixed acidosis. Okay.
I was going to ask what his race has to do with this.
I feel like it's going to be a physician disagrees, but I just don't know why.
With hemodialysis, you're pulling fluid off of a patient. What can that do to your blood pressure? There's two types there's hemodialysis and then there's continuous renal replacement therapy. So CRRT, continuous renal replacement therapy, helps maintain blood pressure. Hemodialysis can actually cause blood pressure to go down because it's a more rapid version of CRRT. So hemodialysis is quick, pulls fluid off the system, but CRRT is sort of like a long, sustained version of hemodialysis, and it doesn't mess with your blood pressure as much. So hemodialysis on a person that's hypotensive,
No.
So,
no.
I think you have to stabilize the blood pressure first before you can do any of like these interventions.
So good thinking. All right, CRRT. Continuous renal replacement therapy. I just talked about that versus hemodialysis. What are your thoughts on CRRT?
A little more safer for him.
Could be
For his
safer for
hypertension, so I think I'd agree. I think the physician would agree with it.
So you think CRT is appropriate?
Do you run the risk of him like clotting from any of these, or?
Not traditionally. I mean, that's part of, there's always risk for any of these, like diuretics, hemodialysis, right? There's always risks associated with procedures like infection, things like that. So clotting, not usually a thing with CRRT that I'm aware of. I'm always willing to be wrong too.
So yeah, like I agree to this one.
Anyone opposed to CRRT? No opposing. All right, physician agrees. Intubation, does he meet criteria for artificial ventilation? Does he have adequate gas exchange and an acid-base balance? Does he have an adequate oxygenation, even with high FiO2s, to maintain where he's at? Or should we go ahead and augment that artificially with intubation and mechanical ventilation?
His
that what it was? It was a moderate on his blood gas.
He had uncorrected hypoxemia with 100% oxygen or high FiO2s, so really, really high FiO2s. There's some data that says non-rebreathers are at 80% is the highest they can give, so whatever you take that for. With a high amount of FiO2, he is not able to maintain an adequate PaO2. His CO2 is also 55. PaCO2 is also 55. Does he meet criteria for mechanical ventilation?
I don't know, because wouldn't the intubation just help with, like, you know, the fractional inspiratory oxygen? So, like, if he's already has high FiO2s, then intubation wouldn't really help his gas exchange, right?
It would help his gas exchange. We would augment it with our ventilator, obviously.
Okay.
But we couldn't try anything like a different mask or anything like that.
I'm just asking, what are your thoughts on intubation? You could say no, I would do something else. That could be the next option on there.
I would try to avoid intubating first.
I'm thinking no.
I'm just iffy because he mentioned there was going to be vent settings. So I'm like, I want to say yes, but I don't know.
Don't let him fool you.
I just made a note for my mechanical ventilation for Mia's test.
Well, in critical care techniques, Mia, did we talk about intubation blood gas parameters?
What I'm trying to find in my notes right now.
Derek, did we get another blood gas after that initial one?
Not yet.
Okay, gotcha. Sorry, I've been putting out fires over here.
You're good.
I want to say no to intubation.
No to intubation?
Just like for now. If he takes a turn, maybe. Well, yeah.
Okay. I guess we'll say
Derek, wouldn't you intubate only if they were like not breathing and not functioning?
So that is what we would call an emergent intubation. There's urgent and emergent or elective intubation. That would be under the elective category. So if someone's trending to the point where they're in respiratory fatigue or respiratory failure, then that could deem augmented ventilation either non-invasive or invasive. In this case, with his blood pressure, his hemodynamics being so odd, something to think about. Could we stabilize him more effectively with invasive ventilation?
I mean, maybe if, what was his, I'm sorry, his respiratory rate again?
34.
34, okay. Well, because I was just thinking, I was thinking back to his like diaphragm and how it was flattened.
Working hard to breathe, sweating.
Yeah, hyperinflation. So, I mean, if you could correct that on...
Hypoinflation.
Sorry.
Yeah.
That might help correct that. And I don't know how I'm trying to explain this. Maybe yes, I don't know. Somebody else choose.
Well, I was just looking at the intubation criteria, and he's kind of like right on the line on some of them. And so I would want to do like more testing, I feel like, and look at his like vital capacity, his NIF, stuff like that. But I don't know.
He doesn't have the mental wherewithal to do a VC in the NIF.
What'd you say?
So then would you do it?
That's exactly what this is about. Do you guys want to do it? Yes or no?
No.
Say yes.
No.
No.
He's in an acidosis. His CO2 is high. Clearly, he's not ventilating appropriately.
But it's 7.34.
Still in acidosis.
Is this the same as like if we tried positive pressure?
So you can do non-invasive positive pressure, or you can do invasive positive pressure.
Okay. We have to get the
So this would be invasive.
hemoglobin.
Well, maybe, yeah, maybe since he's like really teetering on the edge. Isn't that what you said, Mia?
Yeah, he's like pretty much right on the line on some of them. And there's like some tests that I guess you can't do because he's not in the mental status to do that.
So maybe that's another indication too, because he was having the hallucinations and he wasn't like doing super great.
But on his Glasgow scale, he had 13.
No, he had 11.
So he's
11.
okay, 11.
But he's already using all of his accessory muscles, and he can only do that for so long.
Yeah, so right, yeah. So yeah, let's intubate him. Yeah.
So you guys want a tube?
Yes.
Physician disagrees.
Ooh.
What about CPAP? Continuous positive airway pressure. And they want to do it at 10 to 12 centimeters of water pressure. So this would be non-invasive. It's just that one continuous pressure. It helps distend his airways, just like what we do with people that have like sleep apnea where the throat closes off. It sort of helps distend the airways to open things up so he can breathe easily or a lot better with a CPAP pressure there.
That may help with the muscle fatigue, correct? Like, because he's basically using all his accessory muscles.
It could help relieve that fatigue. It could. It has that possibility.
Sorry, Derek.
You're
If you
good.
put him on that though, if we're thinking that he has some sort of like fluid or crackling in his lungs, that's not really gonna, would that help?
So what will happen to alveolar pressure with CPAP? Will alveolar pressure increase or decrease?
That's a good question.
Would it increase with positive pressure?
Mm-hmm. Yeah, so alveolar pressure will increase. So his P big AO2 will increase. As far as capillaries leaking fluid into his lungs, like if that's something you think he has going on, that might help reduce the volume in there because now we're reducing that pressure gradient.
Mm-hmm.
I feel like instead of CPAP, we would want to do BiPAP.
Why do you say that?
Because he's having an issue with his CO2, and I don't know, I'm still really getting the hang of BiPAP and CPAP. But at clinicals the other day, someone was telling me about the BiPAP and how if you set it to a certain setting, like it can help them blow off. Like that as a first line before intubation.
So would you agree to just CPAP 10 to 12 centimeters of water pressure?
Yeah.
You could say no. You're like, no, I want to do BiPAP. You could say that. You could say, no, I want to do non-invasive positive pressure. So just straight CPAP, 10 to 12? Yes or no?
What did you say about the non-invasive one?
Non-invasive, so BiPAP and CPAP. CPAP just gives you that distending pressure to make it a little bit easier to increase your A to A gradient. It's great for oxygenation, and it helps increase your big AO2 in your lungs, right, in your respiratory zone. So that helps that distending pressure in there and make it a lot easier. You don't have as much of a pressure gradient you have to work against to breathe. So it can, to some extent, help relieve work of breathing. However, if you're hypercarbic, you have high CO2 levels, BiPAP or biphasic ventilation adds that whenever you take a breath in, it gives you a second level of pressure. It gives you another pressure to help augment your tidal volume, to make your tidal volume bigger. So it doesn't have you work near as much respiratory muscle. So it augments your minute ventilation even more when you do non-invasive positive pressure versus just CPAP.
I would go with BiPAP over CPAP for him.
I like it. So CPAP, yes or no?
No.
No.
Physician disagrees. Non-invasive ventilation, 10 over 6, that'd be a IPAP or a pressure of 10 and a CPAP of 6. So you have that pressure gradient that's helping them breathe. And then they would set the FiO2 at 1.0 or 100%. Yes or no?
Yes.
Yeah.
Right, because he's hypercarbic, he has high CO2 levels, so we need to augment his minute ventilation. Right, physician agrees and wants you to update them in 40 minutes. So after 40 minutes of non-invasive, we're waiting for the team to put in a VAS cath for a CRT. That's something that we had before. Chest x-ray, physician disagrees at this time because we haven't really done CRT yet, so it's not going to change. What about doing a repeat EKG after we started non-invasive ventilation? Is that going to change? Is that indicated?
Yes.
Yeah.
I think a 3-lead monitor one would be.
Yeah, and this is asking for a diagnostic 12-lead.
Oh.
So yes.
Okay.
No,
Physician
I'd
disagrees.
go 3-lead.
Yeah, so cardiac monitoring's okay, right? But a 12-lead, that diagnostic one, not much has changed. We haven't done anything with his fluid balance, his electrolytes. We haven't done anything there, so it may not change yet. Do you want to recheck his vital signs after you do this intervention of non-invasive ventilation?
Yes.
Yes.
Yes, please. All right. A heart rate's 123. His respiratory rate's now at 38. So he's still tacking away. He's still tachypnic. His blood pressure on his right upper extremity is 93 over 89. His temperature is 35.8 centigrade, and his pulse ox is 88, but very poor heart rate correlation on it. His extremities are very cool and poor perfusion, so you may not get a very good, accurate pulse ox on this individual. All right. So do you want to do a repeat ABG? Now that you know his repeat vital signs, interpret it for me, please.
Ooh. He's still in mixed acidosis.
Yeah.
Yeah, he's still in mixed acidosis.
Actually, his bicarb dropped a little bit, didn't it?
So everything has gotten worse.
Yeah.
Yeah, which would make it more acidic if his bicarb dropped. Yeah.
So do you want to check his level of conscious currently?
Yes.
Yeah.
Poor response. He only moves a little to the sternal rub. That's it. Just
That's not good.
He's
respiratory
declining
pattern.
pretty fast.
What's that? He's declining, yes. Respiratory pattern.
Yes.
Rapid,
Yes.
shallow, persistent accessory muscle use, even on non-invasive ventilation. Not good. All right, suggestions. Do you want to give him a bronchodilator, so Duoneb, and then Q4 hours as needed for shortness of breath? Is this appropriate?
I would
Pharmacology.
you say no because of the heart rate?
So no, because of the heart rate.
Is he constricted? Is he bronchoconstricted?
We heard crackles, and I will tell you that's probably where he currently still is that the crackles throughout the respiratory cycle. And you've seen his x-ray too. Hypoinflated, right? So he has low lung volumes.
Yeah.
Maybe.
I don't think so. I don't think doing that. I don't think doing.
No. Heart rate.
I'm saying no because his heart's already working so fast.
Does changing
But if
this
his heart's working fast to get the blood everywhere it needs to go.
would changing his position in the bed work at all? Would that have anything to do with it? I mean, because he's sitting up. Right?
Yeah, he's sitting upright. And I will tell you that's actually best physiologically for what's going on with him right now. So if you change position, it might his vital signs might change even more rapidly than what they have already.
So if the Duoneb would help reduce his work of breathing, that may actually bring his respiratory rate down. I mean, his heart rate down.
The question is his work of breathing due to a bronchospasm or narrowed airways? If so, that are reactive to a bronchodilator. Now, if it's like inflammation or swelling, they're not going to respond to a bronchodilator because it's inflammation and swelling. That's not the right drug for that. That would be a systemic steroid, right? So when we're looking at this, is the cause of his work of breathing something that can be fixed by a bronchodilator?
No.
No, I
because
think
he
it
is
would be
having
more.
the swelling and inflammation like down in the lungs and down in the that airway, the lower airway.
So Duoneb, yes or no?
No.
No.
Physician disagrees. All right. Therapeutic bronchoscopy. This is where we go in with the bronchoscope with the camera, and we can go and suck out fluid or mucus or just weird gunk that's in there. Or if he aspirated something like vomit or something like that, we can go in there and help remove material for therapeutic. Diagnostic would be to go in there and look and see if there's swelling, if there is samples that we can take and run those for labs. So therapeutics to go and pretty much remove material in general.
Sure.
So do you think the cause of his issues are mechanical in nature, that there's something in his lungs that's causing all these issues?
I wouldn't do therapeutic. I would do diagnostic.
With
but
that
therapeutic wise, we don't have any indication that we need to do a bronchoscope.
Except the x-ray did show that he had infiltrates, which could be fluid in his lungs.
But what if it causes more irritation to like close his airways, or it doesn't help? You know, because we also talked about like, what is it, cardiac tamponade, and I'm gonna say no.
So, and you have to be relatively stable for a bronchoscopy, whether it's therapeutic or diagnostic. Therapeutic bronchoscopy, yes or no?
No.
Correct. Good job. Increase the pressure gradient on his non-invasive ventilation. In other words, make his pressure higher so he has deeper breathing that help with his acid-base balance. So increase his pressure gradients. Make him breathe deeper.
If we decided not to do this one, would our next option, and this isn't like towards you, Derek, but like would our next option be like intubation opposed to keeping him on like the NIV? I don't know enough about this, so I'm asking the other classmates.
Yeah, we haven't gotten this far, so I'm not sure if.
Derek, if he breathed deeper, wouldn't he still be not getting rid of CO2 the same way?
You're augmenting his tidal volume, so you're helping his minute ventilation increase. So you could help him get rid of CO2 and help correct his acid-base balance. But where was his pH? 7.19. 19.
He'd be intubated.
Yeah, that's a pretty severe blood gas. So just going up on his pressure settings,
Won't fix anything.
Maybe a little too late here. Increase his EPAP, well, that's his oxygenation.
Disagree.
Okay, and then give a liter of normal saline. That would help his blood pressure.
No.
Yes.
You guys said yes earlier. Maybe he'll say yes, and he said no. Maybe he'll say yes again. Or maybe he'll say yes this time, is what I was trying to say.
What?
Remember, he's hypotensive, which can lead to an acidosis, right? Low fluid volume, that would be a non-gap acidosis, if I remember right. Could increase his perfusion to his kidneys, increase perfusion to his liver, increase perfusion to his brain, right? Because remember, his mental status is going downhill, like barely his sternal rod gets him to do anything.
And wouldn't the saline help with the heart function if he's hypokalemic, hyponatremic?
Yeah, if he's hyponatremic, it's isotonic, but it could help a little bit there. 0.9%, if I remember right. So give him a liter of fluid.
Yes.
Yes. I knew it. Oh my God.
We'll talk about it. Levofed. Levofed is a vaso.
We don't know that one.
Bedrin, so it's a steroid. It would be a dilator.
A dilator.
Levofed is a vaso constrictor. It helps increase blood pressure. It also helps with myocardial contractility as well. Helps improve blood pressure that way.
I would give it to him just because he's so hypotensive.
So good thinking, because that's what they're thinking as well. Physician agrees. Give an amp of bicarb. Why would we consider bicarb on this patient?
Because he's mixed acidosis, so if he's already in the acidotic level, we could at least try to neutralize some of that, or compensate for some of it.
So 1 amp of bicarb should bring his pH up by 0.1. So if he was like 719, it should go to 729, if I remember right. So is that something we'd want to consider here?
Yes.
If it's only going to get him to 729.
Yeah, but like Sid said, you're kind of like offsetting. At least you're making it better.
Yeah.
Going back to the normal balance of. I'll say yes.
Going with you.
So for those of you, what happens when we give bicarb? What is the end result on CO2 when we give bicarb to a patient? Remember chemistry class and the carbonic acid equation? We give bicarb over here. What happens to the CO2 over here?
It changes it.
It'll cause the CO2 level to go up. He's already hypercarbic.
So no.
But his pH will get better.
I'm going with no.
Like,
I
Then his
love
breathing-
this lecture.
Oh my Lanta.
I'm a solid no.
I'm gonna say no.
I'll say no.
If it were, yeah, no.
It seems like it's not time for small stuff.
So pH of 719 survivable compared to a pH of 729. That's something you got to think about when you're looking at something like a bicarb. Do we run the risk of CO2 because his pH is unsurvivable? Or if his pH is survivable, do we take the risk of increasing the CO2?
Okay, so yes.
And
If
can you
the
manage
main
the
thing to
CO2?
fix is the pH.
Oh, so if we can manage his CO2 by like venting him, it could like, okay.
We've already been trying
And
to
yes,
vent him,
because
though. I don't know. I don't think so.
You know, one thing that, I'm not gonna answer anything. I just want a process in your head too. A lot of medications don't work well when you're outside the 735, 745 pH range. The more acidotic you get or alkalotic you get, the less effective they are. Even pressors at under 6.8 don't work very well. That's pretty crazy, right?
If we could manage his CO2 increase, you could give him the bicarb to get to get his pH balance in a, like you said, a survivable range.
I'm doing the Derek face right now.
Don't do the Derek face.
I know, because I like now I'm so confused.
Leave us alone.
Could you change the dose of like the bicarb, or does it only come in that 1 amp?
They can change it. That's just traditionally the step to do a 0.1 change in the pH.
So maybe we give it to him because he already has poor kidney function to help that out, and then we ventilate to control the CO2.
So yes or no on the bicarb? Now you guys are aware of the controversy around giving bicarb. Which is one of my goals. I hear a yes. Tasha? Who else?
Yes.
Yes?
Yes.
I'm torn.
We have a bunch of no voters. I should have done polls. I should have done that. All right. Physician agrees to an amp of bicarb.
And bicarb,
what's that?
Real quick. So bicarb would be your is that the third line of defense? So it would take the longest to help your acid-base balance?
For your kidneys to create it or secrete it.
So
but we can give artificial bicarb. We can give the medication bicarb. We can give bicarb.
I guess my question is, if the patient in this condition, bicarb would possibly take the longest time to come back to a normal level?
Well, it won't, because his kidneys are in failure, and that's who produces bicarb.
Okay.
Isn't this fun?
You say aren't in failure.
They are. Yes, correct.
Okay.
Roger. All right, intubation, yes or no?
Yes.
Yes.
Oh, that one's good. All right, intubation's performed. They give him an 8.5 endotracheal tube. It's in proper placement.
Yeah.
The airway secured. He wants you to place him on vent settings. So, and I told you guys about this in pulmonary AMP, which vent settings, as far as milliliters per kilogram of ideal body weight, would you put him on? So VT is tidal volume. That's the center area here. Understand, I do have different FiOs too, 60%, 80%, 100%, 100%. So even if you haven't gone through mechanical ventilation, you should know roughly how many milliliters per kilo a normal tidal volume is. And then think about it critically. Would you want to use a higher FiO2 with his hypoxemia?
So
is the normal 6 milliliters per kilo?
For, yeah, all land-dwelling mammals. So when you're looking at someone that doesn't have a restrictive lung defect, you're looking at around 6 to 8 milliliters per kilo per ideal body weight.
And his weight.
He's 5'9" or 69 inches. Any thoughts yet?
So his ideal body weight would be 71 kilograms, so it'd be 71 times 6, so would it be the 400?
Do you want to give him a 6 ml per kilo tidal volume with him being hypercarbic and acidotic as he is, and you just gave him bicarb? So is there something else within the 6 to 8 milliliter per kilo range that could also be appropriate?
Would it be number, I don't even know. Would it be number 4?
I have a vote for number 4 and a vote for number 3.
I'm totally taking a guess not knowing anything about ventilation yet.
So
Just give them
also,
like what you
wouldn't,
said.
wouldn't we want a higher rate as well?
Yeah, number 3 does have a higher rate,
Oh, okay.
but number 4 has a higher
Yeah.
tidal volume. So what's the impact of your minute ventilation? Which one actually has a higher minute ventilation?
Number 4. Oh, wait, hold on.
Are you guys doing math again? Makes me proud.
Yeah, number 4 is a higher minute ventilation, so I would want to go with that one.
All right. Anyone vote for number 1 or number 2? Number 2 has a rate of 20 and 560. It's only 80% oxygen though, but so between those 4, which one do you vote for?
2.
I hear a vote for number 2.
I'm staying with 4.
Did we get his height, his original height?
He's 5'9".
Hint.
Ideal body weight 71.
What is it?
71 kilograms.
71 kilo?
That's according to the Googles.
I think that right there drops it to 2 options, right?
Which are your 2 options, Mr. Justin?
Well, if you're doing 71 kilos, I just say 70 kilos because it's easier math. 7 times 6 is 42. If you add the 0, that's 400. Try to buy 420 or 7 times. 70 times 8. So 7 times 8 would be 560, right? So you have 560 or 420 to 560. So you eliminate one at 800 and you eliminate the other one at 400.
So you're between 2 and 4. Which one between 2 and 4 would be appropriate for
I
someone?
say 4
Now,
because you're
what's-
giving him 100% FiO2. I don't know if that's right.
But then what other disease process? I'm sorry. Did he have any asthma, emphysema, COPD?
Did you say he has subcutaneous emphysema, or is that just what the air pockets would indicate?
No, he was negative for Crepitus. Negative for Crepitus.
So then I would say, would you do 4 because he doesn't have that, or would you do 2 because he...
Oh, Derek, I want to answer stuff.
Also, here's another thing to think about. His hemodynamics. If you put a lot of positive pressure in his thoracic cage, what could happen to his blood pressure with the vena cava? Which one of these uses more pressure, a PEEP of 10 or a PEEP of 5? So PEEP is positive end expiratory pressure. So that's thoracic pressure at the end of a breath, just like CPAP. They just use the word PEEP.
10, it uses more.
So for his hemodynamic status, which one would be more conservative choice?
4.
4.
Dr. Wayne agrees to option number 4, and we'll want you to obtain the ABG after 30 minutes. All right, you are unable to place a radial A line. So they ask you where the next place to get an arterial line would be. So if they can't put a arterial line in the radial, what's the next most appropriate location? So this would be more for our critical care students.
Would it be femoral?
No.
No? Okay. I don't know. We are not that far.
So what's number 3? That's the
Femoral is like in a crash situation.
Is this person very, very unstable hemodynamically, and are they possibly, would they, if that's the only place they could get it, would that be appropriate?
If it's
No,
the only
because
place, right?
Far out. He doesn't even have good perfusion to his legs or to his feet, right?
Correct. And also to his hands too. Remember, our pulse
Derek,
ox
in
is
your lecture today, you said that the second option would be the femoral if you can't do the brachial, right?
correct. So
Oh,
radial.
so it is femoral.
Or would it be ulnar? But you said that's dangerous.
Yeah, I think this femur.
Where are we putting it, guys?
Ulnar.
Ulnar? You inform the student that the femoral location would be the next best. So we have a patient that's intubated, hypotensive, on mechanical ventilation with poor perfusion to his extremities. So the most appropriate site in this situation will be the femoral, and you'll see femoral A lines out there. All right, you place it, you get a subsequent ABG. Please interpret it for me. 7.20, CO2 of 50, PO2 of 66.
We went up a little bit, but it's still mixed.
So that looks like the ample bicarbon, little ventilation helped.
Mm-hmm.
So it's still mixed. Getting better, getting worse?
Getting better.
Getting better. This is sort of the face you guys are all making at me now currently. Just going at it. All right, VAS cath is placed. So they start removal of fluids. They're only doing 50 milliliters every 2 hours, so that shouldn't take his blood pressure too low too quickly. Saturation still low despite removing some fluid. His mean arterial pressure is at 68 millimeters of mercury. What do you know about that? My critical care crowd. Normal is what?
I am totally guessing because I forgot. Is normal above 80?
60 to 105. So
What
that's
does
good.
MAP stand for again?
Mean arterial pressure. So that's systolic plus diastolic times 2 over 3.
Sorry. Okay. So you said systolic.
Plus diastolic times 2, because you spend twice as long in diastole. So systolic plus diastolic times 2 over 3.
Okay.
3 is your denominator.
Derek,
So
what
it
did you
tells
say
you
the number was?
Over 3.
60 to 105. Or what did you say? The
'Cause it
denominator?
says on here, it says 80 to 100 is normal, but less than 60 circulation to vital organs maybe.
Precisely. So a lot of critical care, they'll be like, hey, keep their MAP above 60. Like titrate their levofed, titrate their pressors to keep their MAP above 60. So they do a lot of MAP stuff here. A high mean airway, mean arterial pressure can also indicate heart failure as well. But we don't have that in this case as far as the high mean arterial pressure. Dr. Wayne asked you to make a suggestion on oxygenation changes. So here are your options. You can add nitric oxide, which will pulmonary vasodilate to help with the VQ match in his lungs. You can increase the level of positive pressure in his thoracic cage, or you can increase his tidal volume. I think I only have 3 options there, but is there a 4th one? Yep, 4th one. You can do a lung recruitment maneuver. Inflate his lungs, really open up, distend his lungs, right? They're hypoventilated at this point. So that really helps improve surface area and therefore a VQ match ultimately. So which one would help improve oxygen levels in this patient?
I want to say to
What's
because
that?
does that oxygenation increase the PEEP?
Increased PEEP can add more oxygenation. Just got to be careful of his blood pressure.
I'd say do the lung recruitment maneuver to get more space so oxygenation is better without having to worry about his blood pressure.
So remember, recruitment maneuver, there's a couple different ones out there. There's the 40 for 40 where you take the pressure up to 40 centimeters of water pressure. 40 centimeters of water pressure for 40 seconds. So that's the 40 for 40 lung recruitment maneuver that's out there. What do you think that does to thoracic pressure and squeezing the So that could be even more, there could be even more hemodynamic consequences with a recruitment maneuver, if this is the one that you do, than with just increasing PEEP. We used to give a bolus of fluid before recruitment maneuvers if their blood pressure was sort of hanging on that line there a little bit. So recruitment maneuver, I like it. This version of a recruitment maneuver, because of the year that it's created, I probably would not go that direction. Tidal volume would be a change in ventilation. So between PEEP and nitric oxide, which one would be more beneficial for his oxygenation?
So is nitric oxide just used for infants though?
It is, Justin could verify this for me. It is FDA approved for premature pulmonary hypertension in the neonate, and then it's off label, but it can be used in the adult patient population, unless they've since approved it.
So it sounds like increasing the PEEP is still the best option, just being extremely cautious of his blood pressure and how much that changes.
That could help. The other thing too is if you believed he is in
I'm gonna be a
pulmonary
dark
edema.
horse and go with nitric.
So if you believe he has pulmonary edema, right, if that's one of your things that you think he has going on with this, with vasodilating his pulmonary vessels, his capillaries, would that help with the pulmonary edema, or would that make the pulmonary edema worse? Would there be more fluid flowing into his alveolar space?
Yeah, that would make it worse.
What about if he did have heart failure? Now you're dumping even more volume into his left ventricle.
Right. Well, okay, that may work.
So I guess that leads us to nitric oxide. Add nitric oxide to ventilator.
Okay, but remember, he's in pulmonary edema. That could make it worse. If he's in heart failure, that could make it worse.
Yeah.
Dr.
Yeah,
Wayne
so-
agrees to an increase in PEEP.
Derek.
Okay.
All right. His response after the PEEP change, his mean arterial pressure is now 62. So it's still in perfusing organ area. Subsequent ABG is here. 7.34, CO2 of 45, PO2 of 71 now. We're going somewhere. Bicarb still at 16. Negative 10 and 92%.
So we're out of mixed, or wait, no, we're almost out of mixed. Because it's
We're
still
like-
low. So you're still in mixed acidosis?
Well, now
Well,
it's just a
CO2 is
renal.
normal.
Yeah, that's normal.
Oh, it is. I can't see.
So it's just it's a metabolic acidosis at this point.
Yeah, so we're out of a mixed, and now it's just a metabolic.
Metabolic issue.
Do you think we could do that? What was it called again? That 1 amp of whatever it was, that bicarbon.
So that would take him to 744. So that's almost alkalosis.
Oh, that's true. That's true. Yeah, never mind.
So probably not yet. So he stays on the vent for 7 days. He's weaned off of his levofed, so he's stabilized. You guys were able to stabilize Jack here. He is subsequently extubated and then discharged. He vows never to set foot in the Stanley Hotel ever again. All right, Dr. Wayne asked you for possible causes. This is where you guys get to play doctor. Not in real life, but here. Pulmonary embolism. Do you think he had a pulmonary embolism? Remember, he traveled from LA to Estes, rapid change in flight. He had hypoxemia. He had edema going on. He had a lot of stuff there. Pulmonary embolism. Is that what we're looking at here? A case presentation of a pulmonary embolism.
Well, I have a question. So on the, if you go back to the chest x-ray, could a pulmonary embolism hide behind all of that, like inflammation and fluid? Or would you still be able to see it on a chest x-ray?
Or a significant PE. So you can have a PE and not even know that you have it, depending on where it's at in your vascularity. There was a lady that had like 8 PEs at one time because she was on an oral birth control pill, right? And then she didn't even know. She just had like minor chest pain. She came in and then her sats were like a little low, but they were just so distal, like she didn't even notice. So her x-ray was actually normal. But you can get x-rays that are atelectatic, things like that, depending how significant it is. So yes, in theory, it could have been on that x-ray. However, x-rays are not definitive diagnosis for a PE.
I just don't think it's PE.
So if there's no definitive conclusion to that, what test would we run to determine if he did have one?
So that would be a VQ in theory, or which he disagreed with, or a CT with angiography. Yeah. So that's where we give contrast with it. But that was
well, because he said no to the VQ and we didn't get a CT with angio, we technically can't like really rule it out because we didn't have the diagnostic tools to just like necessarily say he did or did not have it.
So he's also over 65 years old, so he's at a higher risk for it. And drug abuse could kind of help lead to that happening as well. So if he is, you know, getting high on a plane.
And he had blood in his mouth when he woke up.
On his pillow and everything, yeah. So pulmonary embolism, yes, no?
No.
I just don't think we could say.
I mean, it's possible that it's one of the things, but that doesn't explain all the metabolic things that were going on with him, right? Like the electrolyte imbalances in his liver enzymes and stuff like that.
I mean, it could be if he had a myocardial infarction and then a pulmonary embolism was part of it.
He did have elevated troponins. He did have
Eric,
a weird ST segment.
Can I ask you the dumbest question ever? Because I'm a little confused. If he had a pulmonary embolism, how would that make him have a metabolic issue?
If you're
And blood
hypoxic because you don't have blood flow, if you're hypoxic and you're blocking blood from exchanging oxygen and CO2, then you're not going to be able to deliver. Your DO2 is going to be low. Your delivery of oxygen to your tissues is going to be low, which will cause a renal tubular acidosis or a metabolic acidosis, like a hypoxic anaerobic acidosis.
Okay, thank you.
Hey, that's what I'm here for, literally.
Okay, but like if the okay, so if you do think it's a pulmonary embolism, could you tell the doctor to like confirm it with a VQ or a CTA?
That's something that you could discuss. Hey, what are your thoughts on a CTA, right? What are your thoughts on this? That's something you could discuss, but based upon everything you've seen here with troponins, BNP, liver enzymes, renal enzymes, is it a classic case of pulmonary embolism?
He described pain, but did he say where the pain was?
Well, that was what, chest pain? Like he felt like someone was standing on his chest or sitting, like pressure. I remember right.
I feel like we're missing something about the pulmonary embolism diagnosis. I mean, he was a smoker, like we said with the drinking. I don't know, because you did mention the various STDs. Could that play into a factor for pulmonary embolism? I don't know if it can or not.
Not that I'm aware of, but ask Justin.
Okay.
Could it be a pulmonary edema?
Well, pulmonary edema can happen from a pulmonary embolism as well. That can be part of that pathology. But do you think this is a pulmonary embolism that caused all of his issues? Is the question.
No.
Is this the ultimate diagnosis?
No.
Correct. Yeah, physician disagrees. What about a viral pneumonia? It's been in the news a lot since March. Could he have a viral pneumonia? Remember, he flew from LA to a convention. So he flew on a plane to airports, so on and so forth, to a convention. His lung volumes were low. His oxygenation was poor. He did have crackles on auscultation on his lungs.
And his like chest x-ray showed a lot of like just the haziness and inflammation.
Infiltrates. Infiltrate's a fancy word for we don't know what it is, but something's there. So it could be inflammation, it could be fluid, it could be thick tissue, scar tissue. So it's just a fancy word for something's there that's opaque. Something's dense that's there.
We didn't see him coughing or clearing fluids. So
his white blood cells were normal.
His WBCs.
Yeah, he didn't have an infection.
Well, white blood cells would be a bacterial pneumonia, right?
Yeah.
And he had dull sounds, which pneumonia.
Which would indicate some type of fluid.
Well, it's fluid or swelling or scar tissue, or like a pleural fusion.
Derek, every time you hit me with an or.
Wait, just for safety reasons, is that OR, as in metal, or OAR as in a paddle?
OAR as the paddle.
Okay.
For safety, I just got it, Justin.
Yeah, no problem.
Viral pneumonia.
No, because also didn't his temperature stay the same throughout the entire thing? Anytime you saw his body temp. Oh, I'm going with hard no.
Anybody else?
Am I the only one not afraid to be wrong?
No, okay, yeah, I'll agree with Jason.
I'm good at it.
At being wrong?
I feel like it makes more sense than, it could make more sense than the PE. I don't know why I'm fixated on the chest x-ray, but all of that temperature.
But I guess he could, no.
Did Derek also give us the answer on the second one?
That sounds like something I actually would do, because then you'd think no, it would be 9, 10 down. I'd be like, yeah, that's the second one. So that is actually something I try to be unpredictable. I don't know how. Viral pneumonia, yes or no?
It's a possibility. I'll say
No.
I'm going no.
I'm gonna say no.
Yeah, no.
Mia covered both bases. All right. What about a COPD exacerbation? He has a smoking history. You've seen that. Difficulty breathing, right? He had trouble walking up to room 237.
Yeah, wasn't he on a high flow oxygen? And that didn't help him?
Correct. He was on high flow oxygen, and he still was hypoxic, right?
Should we have put him on that, what is it, the Venturi mask?
So the Venturi has the advantage of giving high flow with titrating FiO2 specifically. He was still hypoxic, so he wasn't getting enough oxygen to his AC membrane, enough to exchange with his bloodstream. So if they are setting really high and they just need the extra flow, then the Venturi would be a good option, because then you could titrate FiO2, or he did high flow nasocania, because then you could titrate FiO2 with maintaining a high flow rate to help augment the dead space flow of gas. So in this situation, it wouldn't have helped him because he required so much FiO2.
Okay.
Good thoughts, though. I like it.
We didn't see labored breathing.
He did. He
didn't
was.
see-
He was using significant accessory muscle use. He was diaphoretic.
So would labored breathing apply to using like high accessory muscle use even though it's rapid? Because I think labored is like slow and heavy.
No, it can be rapid, shallow.
Okay.
Right, sternocleidodes, accessory muscle, you name it.
Yeah.
No cough again?
No. Remember, with emphysema, and you'll go over this in disease class, emphysema doesn't usually produce a lot of secretions. Chronic bronchitis, which can be part of the COPD thing, the chronic bronchitis part is what produces secretions, but the emphysema component itself does not. And so they're both under the umbrella of COPD. So like in emphysema, you would just have white mucoid scant secretions.
So he was having bloody secretions, right?
He was.
No.
We also didn't do a whole lot of tests for.
Yeah, we did do a PFT, but was he ever stable to do a PFT?
No.
No. And his X-ray showed low lung
No.
volumes, so it's not an air trapping situation. So he had low lung volumes.
No. So no.
All right, what about HAPE?
I
What
think-
is HAPE?
High altitude pulmonary edema.
Is that possible that he had high altitude pulmonary edema?
Yes.
So yes.
Do you think that's what caused everything that went on in this case?
No.
Yes.
No, I don't think so.
I think for our class we don't know hate that because we're not in diseases yet.
Or it was covered in chapter 19 of your Desjardins book with high altitude.
That was like our last week. I barely remember anything from that.
Let me hear
No,
the
like Derek,
excuses.
we can't like EKGs like totally threw everybody off.
You live at altitude. Just saying, you live at altitude.
I know.
You're going to have these problems. Oh, Derek?
Yeah, you're.
Side note, Derek, I put
I'm
that new
going-
textbook in your mailbox.
Awesome, thank you.
Yep.
So I'm going with yes. I can't see too many things that disagree in the little Oaks book. Because he had haziness of the hilar and vasculature on his x-ray. There is disparity between the upper and lower lobe venous calibers. Damned if I know what that means.
It would also explain the
It could also be yes, because he's not used to that high altitude. Like a lot of people get sick when they're not used to this altitude.
So would that cause cardiovascular effects like his low blood pressure, his elevated enzymes? Would that all be caused because of the HAPE? Would HAPE eventually lead to that?
Yeah.
The ghost would.
So I agree.
The
So
ghost.
does a
It
pulmonary
could.
edema lead to myocardial infarction, or is it the other way around, or can it be both?
It depends if the pulmonary edema is causing such low PaO2 delivery to the myocardium, to the muscle of the heart itself. It could cause the heart to go into failure, right? You're choking the oxygen supply to that muscle, right? It's not going to respond well.
I'm gonna say yes, that it could be the HAPE. Because you said he had rapid, he had rapid heartbeat, which is a symptom of it. The cold, pale skin.
Mm-hmm.
What about his
I don't know if
electrolytes?
they said the sputum was frothy, but they can have blood in their secretions with that.
Would that throw off his electrolyte? Hyponatremia, hypokalemia.
I still don't think it's HAPE. I don't think so.
It could throw off his electrolytes if he's not getting enough oxygen. Wouldn't that screw up his whole respiratory, metabolic respiratory, or whatever?
Well, I feel whatever his diagnosis is going to tie into why the physician wouldn't give him any fluids.
Good observation.
And I don't feel like this ties into not getting any fluids.
Well, he wouldn't get fluids if he was at high altitude, because wouldn't his blood be a little thicker than normal?
Over
So it could
time.
carry more over time?
That's for acclimatization, right? So just initially, if you travel from sea level to high altitude the same day, it's going to take a couple of days to a week or so. I don't actually know the exact number before that starts kicking in, before you start producing more red blood cells and having a higher H&H.
Fully compensated 3 to 6 months, depending on how healthy you are.
Nice.
And what else goes with HAPE, though? What's that other one?
So let's do this one real quick. HAPE, yes or no?
Sorry.
I like where you're going.
Sorry.
So since you said real quick, I'm thinking no.
I'm going to say no, because I feel like you have more room to pull up something. Yeah.
A possible involvement, but the physician disagrees. So there could be some HAPE here. What about HACE?
That would explain his confusion and his lack of mental status.
What is HACE?
High altitude cerebral edema.
So do you think this is a HAPE and HACE situation? Both of them combined. I hear a yes.
Yes.
But what about the electrolytes in the liver?
If he's not getting oxygen to his tissues because of pulmonary edema, then his liver is going to fail and throw off his electrolytes and his liver, and oxygen delivery to his liver as well. So that could go into failure as well, hypoxic.
Would that be the same for his renal function? The fact that he wasn't peeing?
Yeah, because you're not delivering oxygen to your kidneys. Your kidneys require 20 to 25% of your DO2. They're a high oxygen organ. So if you're hypoxic, or hypoxemic, I should say, one of the first organs to suffer is your renal function. And so that's why it's important we look at I's and O's and how much fluid they pee off per hour, neonate through adults. That's something that we look at, because that can also tell us that there might be an acidosis or hypoxemia that's going on that we might have to draw blood gas to evaluate for.
So according to Desjardins, it would explain the hallucinations and the consciousness. But it also says he'd be photophobia, which would be fear of light. But his Perla was decent.
So Hape and Hayes, yes or no?
Going with possible, but disagree.
I'm gonna say yes, I guess.
A possible involvement, but disagree. What about acute kidney injury? He went into renal failure, and that's ultimately what caused his electrolytes, which causes pulmonary edema, which caused all that other stuff to go on. Like, could this whole thing be from an acute kidney injury, right? He's not producing enough bicarb, and so he has to hyperventilate, then he goes into respiratory fatigue and gets dizzy. Could acute kidney injury be the cause? We're pretty low on the list.
How would that affect
I've actually
the X-ray, the chest X-ray?
So if he's not peeing off fluid, he's going to retain it, and that would cause edema, things like that.
Okay.
well, because the AK is the acute kidney injury considered the AKI?
Mhm.
Okay. I feel well. The AKI can definitely contribute to the acidosis. I'm only saying that because I know we had a patient who wasn't doing well in clinic. Her O2 sats were like 84. Any type of movement or talking, she would drop to like 70. And then when we took her to the ED and they got all of her labs back, she was in respiratory, like acute respiratory acidosis. And it all started from her AKI.
His urine output was very poor.
Why he wasn't getting fluids.
Yeah, if you give
Yeah.
fluids to someone that can't pee it off, not a good combo, right?
Let's go with a confused sure.
A very high possibility, if not the cause.
Anyone else?
I'll throw a yes in there.
Yes, but most likely secondary to something else. So he did have acute kidney injury that was part of this presentation. But was that the main cause? Dr. Wayne doesn't think so.
No.
So what about congestive heart failure? That left ventricle not squeezing so well. He did have a history of hypertension with uncompliant with his hypertension medicines.
I would explain the X-ray.
Yeah.
His JVD was normal, right? The JVD?
Is JVD
Yes.
for left ventricular failure or right ventricular failure?
Right.
Regular vein distinction. I think it's right-sided.
CHF would be your left ventricular. Right side would be cor pulmonale.
Yeah, I think it'd be CHF too. Cause that X-ray, like, yeah, I think so.
So, Derek, a question about that. Are you saying that because he did have jugular venous distension, is
He
that
did
abnormal?
not.
Oh, he didn't? I thought he did. Okay.
He did not. So there was no signs on his HENT, like there was no signs of JVD.
And then would that explain on his EKG, if we're looking at heart failure, would that explain the spike in the electrical activity because it was trying to get his heart to beat harder?
How'd it go? So the amplitude would be increased with heart failure.
Okay.
Now, we've seen that his ST segment was delayed or prolonged because of his hypokalemia and hyponatremia. But yes, that would explain the spike. So do you think it's CHF? He did have a high BNP, low blood pressure.
Yes.
Responded well to Levophed.
Mechanical ventilation with adequate PEEP to decrease work of breathing and unload the Levofab is part of the treatment according to Oakes. So, yes.
Anyone think CHF is not a part? I'm getting lower on the screen here, so if you're using that as a...
I'm saying
yes.
So this is a CHF exacerbation with acute kidney injury. Good job. So real quick, there's no diagnostic test technically for heart failure. It's a clinical diagnosis that's made on like history and physical examination. So it's combining a bunch of things together to look at something like heart failure. So breathlessness is usually one of the most common symptoms of left ventricular failure. So that's why a lot of these people, they'll get a nebulizer in the ambulance on the way to the hospital. They'll get a bunch of different interventions. It could be cardiac, it could be respiratory, it could be both, especially if there's pulmonary edema, right? So pulmonary edema is an increase in vascular pressure. If they had a heart monitor in line, if they had a SWAN or a balloon tip flow directed catheter is what they call it on the board exams, it would be a pressure greater than 25 on the wedge pressure. So what you're seeing here is a lot of different things that can go on with heart failure. They'll go into pulmonary edema and their heart's not going to be squeezing very well. So the blood pressure is going to be poor. They can have an altered mental status. So a lot of these patients will look very sick, poorly perfused, like what we've seen with the capillary refill. They'll be restless, sweaty, which is what we've seen here. Tachypnic, right? He was breathing at a rate of 34, breathing really fast. Tachycardic, his heart rates were in the 120s. Hypoxic and coughing, an increased work of breathing. Frothy sputum that can be blood tinged is the textbook definition here. So do those look very familiar to what's going on here? So dyspnea and dyspnea at rest can be signs. Orthopnea, which is a fancy word for?
Breathing while sitting?
Breathing well while...
Oh, difficulty breathing, standing in different position.
So if you do an orthostatic blood pressure, what's the patient doing?
He's changing position, so he goes from laying to sitting to standing.
So this would be, they actually do the best while sitting up. So these are people that classically will be in their lazy boy. They'll sleep in their lazy boy chairs. Like they'll sleep sitting up, sleep in a chair more than sleeping on a bed, because when they lie down flat, that's when they have the hard time breathing. Acute pulmonary edema goes along with this: chest pain, pressure, tachycardia, of course, fatigue. Distension of neck veins can happen with this if it's severe enough to cause right-sided issues. Rapid, thready pulse, they can wheeze as well. You'll see this, people in pulmonary edema will be wheezing, right? So you have this fluid that's in their lungs. Remember, just like a whistle, anything that restricts an opening can cause a whistle. That's exactly what you're seeing here. Increased intensity of the P2 heart sound. Obviously, they can have other issues here: cyanosis, pallor. So brain symptoms with severe CHF thing: confusion, memory impairment, anxiety, headaches, insomnia. These are all looking familiar, right? So sometimes it's usually that delirium that can go along with it in significant cases, right? So what you're looking at here is the heart's ability to contract is really impacted. So usually an MI can cause CHF, but it doesn't necessarily have to, right? It can also be caused by valve problems, or in this case, what caused it? Prolonged and untreated
hypertension.
Hypertension, yeah. So heart failure is ultimately divided in two categories. There's either systolic heart failure or diastolic heart failure. Systolic means the ventricles are just not wanting to squeeze very well. Their contraction's just very poor. When we're looking at diastolic heart failure, it's the heart not relaxing enough to accept blood for more vascular volume. So you can't squeeze out much blood if the heart stays constricted in a small space. The heart's not relaxing in between beats, right? So you squeeze blood out and then it just barely opens up. Squeeze blood out, barely opens up. So that's that diastolic heart failure going on. So they'll have a high diastolic value and a low systolic value. So an ejection fraction is something that you'll see in critical care medicine. Normally it's supposed to be around 60 to 70%, but when it's less than 50%, that's when we're looking at issues with these patients. And at 10% or less, that's usually when they can go into cardiogenic shock. So that's something that you'll see out there. So it's not something we did here, but I want you to be aware of what ejection fraction is how effective the heart is at squeezing blood out. So we're not really squeezing blood out very well. So we're increasing the end diastolic volume, or how much is left over in the heart after each squeeze, which means we're causing a lot more pressure to stay on the myocardium, which means we're going to eventually have a failing ventricle because we're working harder and harder and harder with each beat. So there are different things that will determine this. The muscle can be poor to contract, like with electrolytes. Preload or atrial filling can affect this as well. Increase in SVR or afterload, which is the fancy word you guys covered in cardiac. And then finally, the heart rate is generally increased in these situations. So that's what you're looking at with this. Increase in heart size ultimately makes it worse because the heart is bigger. You have to move a bigger muscle, and it increases the demand of that muscle. So that tension is that Laplace's tension that you can see, and the heart's going to require even more oxygen. So you get hypoxemic, whether it's like with an altitude situation, it can actually make it worse. So him climbing in altitude actually exacerbated a problem he already had. Does that make sense? Hopefully someone gets the picture here. So when you're looking at this, treatment for heart failure, ACE inhibitors, they help reduce extracellular fluid and dilate your arterioles, so that helps with that as well. It reduces afterload and stress on the heart. Beta blockers, you might have talked about this in cardiac, reduces strain on the heart, so the heart doesn't have to work as hard. Diuretics are great at reducing fluid. However, if you're hypotensive, it can make that worse. So something like digoxin might be better, which it helps squeeze the muscle more effectively. It helps that squeeze of the heart, right? Slows, strengthens, and it helps you squeeze out more blood with each beat. Ultimately, you can go on a transplant or even do an LVAD or a ventricular assist device. So there are other therapies that you can do. Fluid restrictions is something you'll see with that they'll have. A low salt diet. They can also do other interventions like pacemakers or cabbage operations. Circulatory devices, VADs, we already talked about that, a ventricular assist device. And then finally, ECMO, right? So this would be VA ECMO, venal arterial ECMO. And so that sort of bypasses the patient's heart from working so hard. It's great for someone that's in cardiovascular collapse. So there's different types of ECMO. There's VV, there's VA. This one would be more beneficial for VA, venal arterial ECMO. What about acute kidney injury? So real quick, I want to cover this. Signs and symptoms, right? You've seen them in this case, and they're usually poor urination, swelling of the legs and ankles. Does this sound familiar? Fatigue, shortness of breath, confusion, nausea, which was one of his initial symptoms, seizures in severe cases, and finally, chest pain and chest pressure. So acute kidney injury in this case? Absolutely, right? So these are all my references, but any questions? I'll stop sharing. I know this went longer than what we were talking about earlier, but hopefully you got a lot out of it. That's the big thing. So questions? You're all on mute for some reason, except for Jason.
When's the next case study?
We can do more. Yeah, I have another Halloween one that's, I think it's Leatherface is the theme on that one. But if you don't want to do a Halloween, we don't have to.
Yeah, that sounds fun. Can we get the PowerPoint to downloads for review?
You want, so do you want the recording or the PowerPoint?
PowerPoint.
The PowerPoint, I think I could work on that if we post it to Denver. I'll work on that.
Thank you.
I also, just this is just sidebar. I didn't have the, I wasn't a part of the class, so I had to ask somebody for the link today because I couldn't get logged in.
That is me. I will fix that right now. So are you not getting? You don't get any of the announcements?
Not for the respiratory therapy students class. I'm not a part of that.
That's good to know. That's usually how I find out if someone goes, I didn't get that. Great job, Derek.